We're here today to show you how to safely give a patient in CT IV contrast. The patient here is already pre-screened by the RAD-RN or the rad tech with the radiologist for GFR, allergies, diabetes, warfarin, and metformin. So prior to the patient coming, the RAD-RN looks at the schedule and checks them for GFR, and we have a GFR protocol. We would like the GFR to be above 60. If it is not above 60, we have a protocol to give them oral hydration or hold IV contrast. And this is also done by the rad tech with the radiologist. In terms of allergies, the patient is pre-screened for allergies. They also sign a consent letting us know whether they're allergic or not. And we either have pre-medication protocol a day in advance, or we have a staff pre-medication protocol given an hour before. If they are diabetic and on metformin, we also have a metformin protocol, which we screen them for. Is our metformin protocol and patient instructions, which we give to the patient. The techs have already are aware that the patient's taking metformin. As I described earlier, they hold their metformin for 48 hours, then do a GFR blood test, and they call the advice RN after the blood draw and see if the test has been normal, and then they can restart the metformin. If it is not normal, the nurse will notify the primary care physician for further instructions. So if you are being called to do IV contrast, it is usually for a patient with a central line, power cords, or PICC line. Hand injection is needed when there is a non-power injectable port, such as an older port, VAP, or one of the older central lines. We use the brown distal port of the central line. We do not hand inject PICCs unless they are powered PICCs. We use a 60 cc syringe. Because the contrast is so thick, we cannot go too fast, but the catheter can only take 1.2 to 1.5 mils per second. And I will show you how we properly give the patient IV contrast.
So right now we're going to load up some contrast. Right now you can see the oval shapes here. That just lets us know that there's air in it. So when we actually load up the contrast, and once there's fluid in it, you'll actually get to see where these ovals will actually turn into circles, okay? So right now we're loading up, we're getting rid of the air. Syringe itself is not sterile, but on the inside it is sterile. And so next the technologist will attach the contrast, set the level of how much contrast we're actually going to be administering to the patient, and then it's going to load by itself, okay? What happens is that it automatically loads up 10 cc's of contrast, and then right now what it's doing is getting rid of the air. So right now, as you can see, there isn't any air left in the syringe. All right. Next, the technologist will attach the connector to the syringe, and we'll make sure that we get all the air out of the syringe. And as you can see, it's bleeding through the line. And we'll just attach this little adapter. What this little adapter allows us to not get any air up into the connecting tube or the syringe itself. So a lot of times when you come into CT, you would already see the injector upside down in the injection mode with the warmers attached. And if you see this on the end, that just lets us know that the line has already been bled. But if you want, you always can check and make sure that the contrast is bled and there's no air left in the actual syringe.
After the nurse makes sure that this is fully primed, either we will access the patient's port or central line, or if it is already accessed, we double check by flushing 10 cc's of normal saline, and then we hook this up. Okay. And then I will show you where we push the button for IV contrast. When the RN comes in and makes sure the patient is hooked up, the tech has the appropriate timing as to when you push the button. So you do wait until the tech tells you when to push. Here is the start button. Here is the stop button. When the tech tells you to push, you just push the start, and that's about it. Unless there's a problem, and if there is a problem, you just push the stop button.
As far as timing goes for the injection, a lot of the studies are pre-programmed, so there's no worries on them. Like for instance, if we're doing an abdomen pelvis, it's already pre-programmed for 70 seconds. Chest is pre-programmed for 40 seconds. The only exam that we really have to worry about are the PEs. There's no timing set for that, and we got to be pretty precise on that. So whenever, let's say for instance, we come down with an inpatient and they have a power pick in, we'll let you know exactly when to press it. That way we can be precise at the same time. Other than that, it's pretty straightforward. And also for nurses that come down and they worry about radiation safety, the threshold is really at the door. But what we like to do before we even start the study, we make sure nurses are in at least 3 to 4 feet in, so that way we're 100% sure that we're safe as far as radiation goes. So we won't start the exam until we know everybody else is behind that threshold. Just like that, okay? So what I'm going to do now is start the injection. I'll start from the outside instead of the inside. Press the yellow button to start it, and the green button to start the timer. Any pain? Let me know when you start feeling warm, okay? It's flowing in very well. I can feel it. Keep your arm just like that, okay? And I can show you the graph inside so that way you can know how the flow rate is going also. As you can see here, you can see the graph, and it's showing you the flow rate, how it's going in. So it's a good steady flow going. If there was a kink in the line or something, it would have peaked and hit that red line, and it would have stopped the injection. Okay. So as you see with the graph, we got a nice steady flow going. To keep a flow like that going with the patient, you want to make sure the arm is completely straight. No kinking with the catheter. If there was a kink in that catheter, you would have seen the graph, instead of going straight, it would have peaked and hit that red line. And instead of going at a flow rate of 3 or 4, it would have stopped the flow rate down to 1. And that wouldn't have been an optimal exam. So try to make the arm as straight as possible to get pretty much a good study.
Once you've pushed the button, it's very important to stay here until the study is finished and until you've assessed the patient post-IV contrast. Sometimes some patients may have some complications afterwards. One of the possible complications is allergic reaction. If they do complain of itching, hives, not feeling well in any way, you do stop the IV contrast. If you suspect there's an allergic reaction, we do have a protocol here to follow for allergic reaction. Includes a treatment for itching, bronchospasm, hypotension, bradycardia, and hypertension. There's the treatment. This is for adult. This is for pediatric. In addition, we also have a pediatric dosing by weight here that will be here. In the Pyxis, we also have a kit. You can override and press kit, and you can find the dose there.
So if I'm coming from a different department, is my patient going to be in this Pyxis?
You can access your patient. If the patient is not accessed, you can add the patient and then override and do a kit.
Okay.
In addition, we also have a crash cart, and you can remove emergency meds from the crash cart as well.
So, but all emergency department patients should be
All
in there?
emergency department patients are in the Pyxis.
Okay.
Yes. After the IV contrast, another possible complication is extravasation. It is very rare, but if it were to occur, we have an extravasation policy and protocol. We stop the contrast. We notify the doctor immediately, whether it's the ED doctor or the radiologist or HBS if it's an inpatient. And we would stop the study, and We would ice the area, and we would wait for further instructions from the doctor. This form is a contrast extravasation patient instructions, which the patient will take home with them in the event of an extravasation. They apply ice packs to the area for 10 or 15 minutes, 3 or 4 times a day for the next 24 to 48 hours until the swelling resolved. They elevate the area as much as possible. The RAD RN does contact them the next day to see how they were doing. The RAD tech notifies the RAD RN if there is any allergic reaction or an extravasation for follow-up. A third possible complication is that after the study, the patient may feel dizzy, lightheaded, and feel like he's having a fast heart rate. If this happens to your patient, first you assess your patient, you take vitals, and have them slowly sit up and give them some water. Usually this feeling of dizziness, lightheaded, and fast heart rate is as a result of not being well hydrated prior to the study. And usually drinking some water resolves it all. However, this is not always the case. If the situation does not resolve after 30 minutes, patient may need to be taken back to the ED, notify the radiologist or HBS of the situation.